Well, hello everybody. My name is Virginia. I'm the Chief of Residence in the Internal Division Department at the Centenary Hospital in Rosario, Argentina. Today, I bring you the case of a 28-year-old cisgender woman diagnosed previously with systemic lupus erythematosus with a lot of clinical features. She was on ongoing therapy with prednisone and hydroxychloroquine. She underwent in 2021 a first hospitalization due to cholestasis. A liver biopsy was performed, and an indeterminate autoimmune cholestatic hepatitis was diagnosed. During that hospitalization, she developed a fever, and a chest CT was performed showing micronodular lesions and triene-bud pattern. A bronchoalveolar lavage was performed and was negative for acid-fast bacilli. During that hospitalization, azathioprine was introduced. 6 months after these hospitalizations, she developed some skin lesions. They were nodular lesions on both lower limbs, initially suspected as azathioprine related, and because the symptoms attributed to her lupus were really present, she was screened for a clinical trial, and a positive quantiferon TB test was positive. She still was on prednisone and hydroxychloroquine. After that, in 2023, she underwent a second hospitalization due to progression of the skin lesions, as we can see on the image, with the development of deep ulcerations that were really painful and impaired the quality of life of our patient. These were the lesions when she was admitted at the first time. A skin biopsy was performed, and lobular paniculitis with vasculitis and granulomas, both at septal and lobular levels, was found with a Nielsen and PAS stain negative, and also cultures for the skin biopsy. She developed again fever, respiratory symptoms, and lower back pain. An MRI of the ¿cómo se dice en español? Well, we did an MRI, and with the patient, we found a spondylitis at the D4 and at the D11 and L4 levels. Okay, so a bone biopsy was performed with the appearance of cacheating granulomas, and at this time, we found a positive gene-expert MTB in the bone biopsy. Regarding the lungs, a chest CT was performed again, as we can see, and the images of the lung were worsened with a lot of nodules and triene-bud pattern. So we did, in these times, a BAL, again, negative for acid-fast bacilli, and a lung biopsy was performed, and this time showed interstitial granulomas and Langerhans giant cell. So in this moment, we diagnosed secondary tuberculosis, so first-line anti-tuberculosis therapy was initiated. So in the outpatient follow-up, the patient completed a 1-year treatment regimen with anti-tuberculosis therapy, and due to progression of the alopecia, oral ulcers, and everything that was regarding her lupus, mycophenolate was introduced, and 1 month after the introduction of mycophenolate, we could see worsening of her skin lesions. This is the lesion that we see previously. The patient in the follow-up before the introduction of the mycophenolate, the lesions were stable, but now they were worse. So in this time, we did a new skin biopsy, and that showed a granulomatous dermatosis with caseous necrosis, and we found a positive gene-expert MTB RIF. Remember that the patient completed 1 year of first-line anti-tuberculosis treatment. So Bazin's disease was this time diagnosed. After the diagnosis, the patients restarted first-line anti-tuberculosis therapy. Mycophenolate obviously was suspended, and we introduced rituximab due to the activity of the lupus. Regarding the lupus, she presented a really amazing response to rituximab, and she is actually ongoing with anti-tuberculosis therapy. So regarding clinical considerations, Bazin disease is a really rare necrotizing granulomatous dermatosis. We face a really elusive diagnosis. Remember that the patients first had the micronodular lesions in 2021, but we found the bacillus 2 years later, and we suspect that a refractory autoimmune disease increases susceptibility to this pathology. So, regarding the diagnostic reasoning, we initially aligned with Occam racers, and we think that the initial lesions were lupus paniculitis, but applying Higam's dictums, we, thereby broadening our diagnostic, we think that there will be coexisting conditions. Through a structured clinical reasoning and systematic diagnostic approach, we ultimately lead to accurate diagnosis and the most important thing, in improvement in the patient's quality of life. So, and last but not least, since I know I have a few seconds left, I want to mention that nor my education or the treatment of the patient wouldn't be possible without public health and public education. So I'm really proud to bring this case to you, and that's all for it. Thank you.
Thank you very much. Now let's move to maybe a short comment from Mr. Mouton.